Hi, I'm Dr. Reggie Sangha, the Medical Director for Content Guru. It's great to be on the panel session today at the Virtual Wards Conference up in Manchester. And we had a lot of interesting questions put to us and topics of discussion about challenges that virtual wards organisations are facing. And so sort of really, how do we overcome barriers of digital poverty, digital exclusion? How do we make sure that virtual wards scale up and ensure that organisations are keeping on top of it, data security? There's a lot of concern around security breaches, and that's one of the things that we specialise in at Content Guru, is that we deliver large-scale technological solutions that are incredibly sophisticated. We keep abreast of the most recent and current technological developments, and also we are incredibly robust in how we manage our information governance and data security, and we adhere to all the regulations and guidelines, including those in America and FedRAMP and so forth. So it's a really interesting panel session, and also a lot of interest in the generative AI and how we can make sure that we harness that safely for the good of the NHS.
Okay, hello everyone. It's good to be here again. So I think Douglas alluded to the LinkedIn post I did yesterday, which probably no one else has seen, so it would be helpful if I explained it. We were thinking about pondering the biggest barriers, which is what we're thinking about now anyway. And you hear people talk about the tech, you hear people talk about the lack of interoperability sometimes. Obviously workforce is a key one. But I was focusing on the people, all the people. The commissioners that we need to get the clinical, commissioners that you need to kind of get this service, justify the service, get the business case done, etc. The clinicians to get that confidence to really buy into it, and generally, you brought that to life in your presentation just then. The patients, we want them to have the buy-in as well, to want to be a virtual ward patient, to be comfortable, be choosing at home, to feel that it's safe for them. And then us, people like me, managers, we have to kind of make it happen, do the change management bit and make it stick, make it sustainable. But we don't always get all those things right, and the human variables are, I think, the biggest challenge we have. I will pass over to my other colleagues now to comment. Thank you.
Hi, I'm Dr. Reggie Sangha. I'm a GP coming up to my 30-year work anniversary next year, and also Medical Director for Content Guru, which is a large cloud contact communication software company based in the UK. And every single 111 and 999 call goes through our cloud. Already this morning, it's only 10:30, 10:45, and I've heard loads of really impressive stories actually about virtual wards and actually how much money they are saving the health economy and how popular they are with patients. And I think we've got to get the message out there. The issue is the funding's no longer ring-fenced, but the people in this room have come here, and there's some amazing success stories, and it's going to be incumbent on these groups to make sure that that data and information is fed back, because that's what builds reassurance. That's what will help take this forward, because going backward is not an option for us. Digital is here and it's here to stay. And it is patient-centred care. And I've had a lot of experience in change management and introducing technology in different environments into healthcare and justice for prison services, which is very hard to recruit into, and in other very tough environments across 111, in winter pressures and so forth. But the stories I've heard already this morning are impressive. So I think it's critical that we sort of build on those successes. And there's barriers, but as Prince William said earlier this week, there's a new phrase, stubborn optimism, and I not blind optimism, but stubborn optimism, and so we need to make sure we capture all that learning.
Thank you. Morning everyone, my name is Santosh Kumar, and I'm a lead data scientist at Health Economics Unit. So I'm going to present more as a technical or AI or machine learning perspective, how basically the machine learning and AI could be really, really useful to implement the virtual ward. especially a virtual ward, which is a kind of very diverse scenarios. You have to implement in a very diverse population. There are like so many referral pathways could be there. There are like different treatment pathways could be there. And then imagine like we have, every hospital or every trust have a different staffing and resource management implementation there. So how basically we can combine this different knowledge into a one system where you can have a kind of a unique or kind of standardized way to getting your data, not only on the patient level data, but you will able to basically compare the inpatient care by using the machine learning and AI. So my team is quite like in expertise into like patient flow modeling implementation, especially into the scenario modeling. And recently in one of like our emergency urgent care modeling, we have like implemented the virtual one of the pathways like the virtual wards there, and then we found like while having this virtual ward into your like pathway modeling could be really beneficial. It gonna basically help you to reduce the wait list.
Thank you very much for that. You cannot have the conversation around data without talking about the elephant in the room, and that is data security. You'd be aware of ransomware and cyber attacks on unfriendly parties. How then do we reconcile the risks of AI when we're pushing out virtual wards?
Yeah, I think in my opinion, whenever we are using like that, we are getting like a different kind of multimodal data from the virtual wards. For example, from our monitoring system, from our like entire virtual ward. So we need to take care about like what information basically we are using as a process of the information from the patient. So in my opinion, like when we are implementing any machine learning algorithm, for example, risk certification, or you want to predict like a adverse outcome from the patient, you have to use kind of the minimal data, like the data which is absolutely required to basically build your model, rather than entire like multi-model data is coming to there. So this is a really key point in my opinion. Thank you.
Yeah, thanks for that question. As you can imagine, working in a large cloud computing technology company, cybersecurity is absolutely critical in this day and age. We're living in a complex world and complex models. So, actually our customers that we provide cloud computing to is that they're very concerned about this. So that's why we have UK-based data centers, and we have to abide by all the really strict GDPR regulations. But it's a really fast-changing world, and it is scary out there. Some of the breaches, the security breaches we found out recently in the London labs. That's why you need to be ensuring that you're partnering up with companies that are incredibly robust and resilient in their security checks, and asking how, for evidence of how they're sort of ensuring that they're maintaining their cyber resilience. So just on the point of some of the assistive AI technology, we're working with London 111 at the moment on some really exciting AI projects, and what we do is we're just making sure that there's UK-based data sovereignty. We're ensuring clinicians are there, working with the lead data scientists and working closely with the commissioners to make sure that, because whilst it's very exciting, it's also a time of, ensuring that we're taking, the right steps in a pragmatic fashion to make sure that that we can assure organisations that we're getting the best out of AI. But if I said to you today that there is assistive AI technology out there that could save GPs 2 hours a day of their time, and hearing that information about nurses spending a third of their time writing up information, that technology absolutely exists today, and part of my mission to make sure we get that out there.
Yeah, good question. Also, well done to the London Trust that came together to support when we had that recent cyber attack, and it was cyber reported. I think with the data security risk remains the same regardless. And obviously there is a lot of work that's already been done around the information governance side of things as well as the data security side. The bit with the AI that I find interesting is we've essentially been using a lot of that approach, the machine learning approach that you mentioned. It's not new. I worked on the first NHS testbed for remote monitoring, and that was 10 years ago. And we were using machine learning to enable to calibrate for what's normal, what are normal levels for an individual. So it really helped to personalise care. It was fantastic. That approach that we have with many of the technology providers and virtual wards, where you have the dashboard and the alerting, is essentially a sort of smaller, scaled down version of that. But as we start to see more AI being introduced into some of the tools that we have now, we'll be able to get that machine learning capability to help to support clinical decision making more. I think the risk that people worry about when they start thinking about the new shiny AI is an AI bot basically making those clinical decisions, and how we manage that risk and how we kind of ensure against a rogue AI making bad medical decisions. We're definitely not at that point yet where anybody's been suggesting that our virtual wards are run in such a way, but there are some really interesting research pieces done, and like you said, there are some really good opportunities to save clinician time, and also sometimes to have a second pair of eyes for, our clinicians work really hard, so sometimes it's good to have a fresh pair of eyes. So I'm quite excited about the new advances that are coming down the line, but I think we're pretty good at being quite cautious in the UK, and I think that's important that we keep to that way, and keep having discussions and develop frameworks together. It's really important that NHS are part of those conversations with the private sector, with the technology suppliers and developers. It's got to be collaborative.
You're fantastic. And can I have a quick show of hands? Any one of you got experience at trust level or organizational level rolling out virtual chatbots, virtual assistants to your communities? Anyone? Show of hands? Just 1, 2? Virtual assistants? Chatbots? Okay. What's been your experience with recruiting? From a patient's perspective?
People like it. They like it when it works. So,
Okay,
that's been our job, to make it work.
Okay, cool. Anyone else in the building gender pro today after practice? Anyone else? No? Okay, go ahead. You want to shout?
Yeah, it was developed by students for students, just welcoming to their mental health. So I ended up with them designed it and they implemented it.
So there's a collaborative element to it.
They asked for what they in this task, not all to.
So that's brilliant. Still on that? Okay, cool. The reason why I asked that question is, the next question is about adaptability. When we're offering virtual wards, giving the customer choice to how they engage with the health service is so important. So how adaptable are we in the practical sense of the word? So I will go from, let's go Reggie, Francesca, and then Santosh, please.
Well, I mean, adaptability is key. You know, every population is different, and the needs of the populations are different, and, you know, depending on the age, whether patients speak English as their first language, all of these, and what conditions are we trying to treat and manage, you know, and what part of the healthcare spectrum are you sort of working from? So again, you know, every solution needs to be worked through collaboratively, and I agree with your comment earlier about you know, that it needs the NHS, the technology sector, the independent sector, the social sectors, to come together. Otherwise, it doesn't work. So, and it needs to be sort of geographically based, absolutely. But learning from success stories is also key.
Yeah, I think we need to, be more adaptable, shall we say. But I think we have an opportunity to do that with when we look at the technology side of it. So you have, the gentleman talked about lanyard agnostic, which I love, but also a lot of these platforms are product agnostic as well. So you can have a variety of, or develop a variety of different virtual ward pathways. But if you've got one platform, then that means that you've got opportunities to join some of those dots within the platform, even if you've got different EPRs at working in, so community might have one and the youth's got another, but you've got this kind of virtual space where you can collaborate and have an MDT approach. That kind of flexibility, I think, is where the opportunity is. So there's a few early bits of work in London around looking at how we can join up some of the long-term condition remote monitoring and the virtual wards remote monitoring by way of it being done in the same platform. And then that in itself, we can be more adaptable. We can start planning to escalate into a virtual ward for somebody, even when we know that their long-term condition has been exacerbated, which that clinician then at the virtual ward will have all that longitudinal data because the patient's been already on their platform for a little while. So we're just starting to play with some of these opportunities, and that adaptability is going to be for the technology, but also for the patients, so that the patients can seamlessly go on that journey without having to keep kind of checking and changing different bits of kit and different teams. So lanyard agnostic for the patients as well as what we're trying to get to.
Thank you. So as both of discussed, like the adaptability is the key. As I mentioned about like, because she mentioned about like we have a different populations, like different segment, and every characteristics are different in terms of the patient. So achieving the adaptability is a really difficult here. The difficulty is about because you have like a different kind of referral ways at the pathways. You are basically dealing with the different kind of diseases there. So getting kind of a standard platform is a really difficult. So we need to also same time think about whenever we are implementing the virtual ward, we need to be implement in a local context so that they can basically get a local insights from there. And also I think the adaptability will become like when you get the acceptance, like at the wider scenario. For example, for that you need not only like the patient should have a digital literacy, but also like our resources as a nurses, as a doctor, or as other resources in our system should also have a digital literacy about like the basically these tools or like the monitoring tools we have inside the system.
Oh, thank you. Now, in terms of scalability, we have seen a discussion around virtual wards being played out for 5 to 10 years now. It's been going on. Why do you think it hasn't scaled, it hasn't Uberized as such? Many health organizations are still talking about turning 5 to 10% of their physical beds into the virtual space, and that number seems to have stuck. How come we've not managed to Uberize and really scale up virtual wards to at least have parity with the physical beds virtual? So I'll go to Francesca first, and then Reggie, the Santosh thing here.
Well, I'm not sure we ever had started out with that ambition, to be fair, of how to do the same amount of virtual ward beds as inpatient beds. I always thought, and someone says, well, when are you closing the hospital then? We're not going to close the hospitals. But what we are doing is create a capacity in the system, and what we are doing is allowing people to, if it's appropriate for them, be treated at home, which is often a much nicer option from a patient perspective. Why have we struggled with scaling? I think there was the pandemic where everything went crazy and everybody remembers that, and there was lots of money thrown at the system at things like virtual wards. And then when that kind of calmed down a bit, we got into an actual national programme which was funded, and as you mentioned earlier, they took the ring fencing away quite soon. But the ambitions, it was definitely set as ambition from the national team around numbers of bed days, and they quickly revised that initial one down to quite low because there was quite a lot of pushback. The system was not in a position to be able to deliver that. We've been scaling slow and steady, I think, in London, and I feel like that's the same in the other regions. Yes, it's about funding, but that's not the only barrier. Workforce obviously is always a challenge. I do think we still have some way to go with getting the buy-in from the people that count, including the clinicians and including the CFOs who need to get behind these things. And part of the challenge with that is we're still developing a repository of evidence. The evidence that can convince the financial people, the evidence that can convince the clinicians. For whatever reason, we haven't had lots of robust evaluations done. We're starting to see more come through now, and PPL have done some good work in South East London and the South East region that's helped to kind of shift the dial a little bit on that. But there is still a few reports and a few studies that have come out showing that this is a costly approach to care, and that makes people nervous. So I think we do need to, so in London, one thing that we are doing at the moment is we've commissioned some work with the Health Innovation Network South London and York Health Economic Consortium. So York already had developed an economic modelling tool for virtual wards. We engaged with our London systems, and we've had some developments and some changes, updates for that tool. And what we're hoping to get to is a place where everyone in London is kind of using that same approach to model and evaluate their virtual wards from an economic perspective. That's going to help us in terms of standardising, comparing, and hopefully improving value for money. And then the knock-on effect should be that scaling becomes that bit easier. So I think I've spoken a bit too long on that one. There you go.
It's really good to hear. I'll be wanting to read that as soon as that comes out. I think I'm not going to say anything extra there, but I think that, yeah, absolutely, when ICBs have faced funding cuts of a third, you know, there's been a sort of rowing back since COVID, which has been a bit depressing across the system, but we're in a new era now, so let's hope that, because you do need funding, and when you're pushing out a new digital idea, you know, it does need a push from central government, really, and so the sooner we get reports like this out, and absolutely getting the data back and to win over the hearts and minds of resistant clinicians and so forth, then the sooner the better that will help. And we also have to think about, you know, is our infrastructure, you know, our technical digital infrastructure ready for scaling up? You know, what, you know, have we got the cybersecurity in place? Have we got the right, you know, digital architecture to support large-scale virtual wards? Because let's face it, you know, the population, it's aging, you know, we need solutions. It's not just about bricks and mortar.
Thank you. I think well said with my former speakers. I just want to add, like, yeah, the same is like the resource is really key. Like, we are really lacking with the resources. Think about in the the current virtual ward scenario. Where is the staff? The nurses are coming. They are coming from the existing system. We are not recruiting like the kind of dedicated nurses which could be really dedicated for the workflow of the virtual wards. So we need to take care about the infrastructure, also like the resources what we have. I think the two key are lacking behind, so that we are not scaling up really in the large scale.
Can you just add one thing to that? I just thought the only thing I wanted to mention was health inequality risks, because yes, it's absolutely important to scale, but we need to be doing it at the same time as recognising developing some initiatives to reduce the health inequality gap, because there are, from anecdotal experience, clinicians turning up to people's homes where they should never have been put onto a virtual ward because it was an unsafe environment for them at home. Also, but what happens next? So how do we, if we realise we surface things like, we'll go with the mould example, somebody's living in a home that has black mould, for example, and maybe they're a local authority resident, and maybe the local authority's got a very long backlog for maintenance and it's not going to get fixed anytime soon. How are we in health and social care and local authorities going to work together to, once these kind of risks are surfaced, ensure that people are having whatever they need to be done so that they can access virtual wards as well? So there's lots of reasons why they might not be able to, but we do need to think about that and work on that whilst we're approaching scalability as well.
They're fantastic questions being posed. I've got time for one question from the audience. With the one sway on. Gentleman over there.
Hello everyone. I have one question. This is centered on a patient who had a lot of talk about the technology that's being deployed within community. question here is what are we doing to ensure that requirements that allows patients, say from the private backgrounds who are digitally illiterate, to begin to get on the platform, be able to, easily use the platform, because I think that's itself actual. The technology is there and the patients are not comfortable using it, and then it means that the data that we capture may not be very reliable, and it will have a knock-on effect.
That's a great question, and could you all answer that 1 minute?
I'll go first. That's a brilliant question, and we don't want digital exclusion or digital poverty. And I know I'm going to answer that with a technology solution, actually. So you can have sensors that take away the onus of responsibility from the patient that will be transmitting data into digitized platforms. But on top of that, now we are on the cusp of a new AI era where we have got incredible AI-assisted translation software that will reach out to all those communities that may well have felt disadvantaged. And the use of sort of voice technology, voice translation technology is I've seen it with my own eyes, and it's phenomenal. So we need to reach those groups, and I believe we're going to do that.
Yep, I think that's a really valid question. Especially we are like having an aging population. Especially they are the segment of the people who don't have any like a social network. They don't know how to access the internet. So it's a really kind of, we are lacking behind them into when we are implementing some kind of intervention, let's say. For example, the cancer screening is one of the example. So here, like the AI, especially the data-driven approach, could be really, really helpful to basically doing the segmentation around those population who don't have a digital literacy. And then we can basically targeted them online and the offline as the both way, and then try to basically give them more training, give them like more interaction, like how the system is working, and then how basically the virtual ward could be helpful for them. So I think the data-driven or AI approaches could be really, really helpful in this way.
I'm going to be uncustomarily quick. My advice is lean on volunteer services. They're really good, they're really helpful, and they've got people skills, which is important. And for digital poverty in terms of devices, engaging with the Good Thing Foundation as well.
Fantastic. We've round of applause for our excellent panel.